Today we're going to cover chapter 18, which is all about drug abuse. We're going to talk about a few drugs that are commonly abused. We can categorize drugs many different ways. I have categorized them basically in really typical categories that are pretty much like the type and chemical structure. We're going to talk a little bit more about how you can categorize drugs later. And of course, you can argue about abuse potential or chemical structure, and we will kind of focus on the major points of each type of commonly abused drugs. So we're going to cover opioids, stimulants, alcohol, and cannabis, starting with opioids. Now, one thing I want to make sure that people understand is that there are two terms that we typically use when talking about opioids. So there's opioids and there's opiates. And so opioids and opiates are often used interchangeably, but there is a difference between the two. So opioids, this is a very general term and includes all the different types, whereas opiates just refer to natural types of opioids, okay? So these are ones that are binding to our natural receptors that occur naturally. So a natural opioid, for example, would be heroin. So heroin, morphine, codeine, these are all natural opiates. Now, because they are natural opiates, they actually do fit into the category of an opioid. So opiates are very specific, naturally occurring opioids, whereas opioids is a general term that does refer to natural opiates, but also synthetic and semi-synthetic opioids. So if I say an opioid, okay, so an opiate is an opioid, but not all opioids are opiates. So it can get kind of confusing. So I've pretty much labeled everything as opioids since it's the more general term, but know that a synthetic opioid might include, for example, a synthetic one would be methadone. That would be a synthetic opioid, whereas a semi-synthetic opioid might be oxycodone or hydrocodone, things like that. So, just to kind of know that there is a difference between the types, and even though people use the word opioid and opiate interchangeably, if you want to stay safe, use the word opioid because that's going to include both natural and synthetic and semi-synthetic types. So what are opioids? Well, they're a class of drugs derived from the opium poppy. They're primarily used for pain, and this is what the word analgesic means. And so many people are familiar with how they're used because of, what we know about opioid overdose and opioid addiction. It is highly addictive. Opioids are highly addictive because we actually have opioid receptors in our brain, and they're binding to these natural receptors. So it's an easy kind of connection because we naturally have these already. We know that there are a lot of effects that opioids can have on the body and the brain. Analgesic, of course, analgesia is pain, and so it helps to relieve pain at the level of the brain. It's also shown to give people euphoria or a sense of high and happiness. It can also be used as a sedative because it does, sedation is one of the effects. And it can also, especially in the cases of overdose, cause hypothermia. We know that these areas of the brain that it responds to also are important for thermoregulation and temperature regulation in the brain. So you can actually experience drops in body temperature as a result of taking the drug. So how does it work on the brain? Well, opioids depress the central nervous system. It can produce a stupor and basically make you out of it. Heroin in particular diminishes inhibition, which means that you're going to be, you're not going to have the ability to kind of stop yourself from doing things like saying things or acting things out when normally you would have been able to stop yourself. So it's going to diminish that inhibition. Also increases positive feelings in euphoria, and it gives you that sense of high. Now, even though opioids do have a very high abuse potential, clinically, they're really important. And they have been important for hundreds of years. They've been used for pain management, and they've been used for as an anesthetic during surgery, for sedation. It's a very good antitussive, meaning that it suppresses cough really well. And in fact, in 1889, Bayer had a medication, a cough suppressant that had heroin in it because it does such a good job suppressing cough. And one thing to note, though, is that you can develop a tolerance for the analgesic effects. So if you're taking an opioid for pain management, you have to be really careful about dosing, because you might find, oh, well, I'm taking this pill and it's not doing it anymore. It's not, I'm starting to experience more pain. It's not reducing my pain as much or at all. And so if you do take opioids for the long term, you should really have a pain management plan with your doctor to decide, okay, well, maybe this isn't working anymore. Do I need to increase my dosage? And so that would have to be in the plan with the doctor or the physician, not just the person saying, well, I'll just take 2 pills today instead of 1, because that can be really dangerous. And typically that's where we see addiction forming, is when people start not taking their doses as they're supposed to, and then it starts getting out of control. So that's certainly a way that we can see addiction start to happen. Abuse starts that process, and then the person becomes, and abuse and addiction kind of go hand in hand. So we do have opioid receptors, and these receptors are specifically in our brain in the limbic area, so like your limbic system. It's also in your hypothalamus, in the areas that are projected from your hypothalamic areas. And so this is also kind of really important, because the hypothalamus helps control a lot of things and does work with body temperature and appetite and all that as well. So these areas are all sort of interconnected. We do have 3 main types of opioid receptors naturally in the brain. And those are delta, kappa, and mu. All of these receptor types are metabotropic, and if you remember from previous lectures, you can have metabotropic and ionotropic receptor types. And so metabotropic make up about the 80% of the receptor types that we have, and those tend to be slower in terms of producing change and in terms of just in general compared to the ionotropic receptor types. We do have endogenous opioids. A lot of people don't even realize that endorphins are actually considered an endogenous opioids. Endogenous, of course, meaning natural in our body. Exogenous, so exogenous, with EXO. That being outside of the body, so taking something that's not naturally occurring would be exogenous, whereas endogenous is something that's naturally occurring in the body. And we talked about agonists versus antagonists, if you guys remember. Antagonists a lot of times will block a drug or block a chemical from connecting to a receptor. And so one example of an opioid antagonist is naltrexone. And so what naltrexone does is it is able to block a very specific effect that is seen in alcohol. And so it blocks the receptors so that a person who is using alcohol doesn't experience that sort of high, that euphoria that you typically will experience. And so it makes consuming alcohol not only does it make the person sick, but it does make it less desirable because they're not really getting anything out of it in terms of their reward pathways. And so this particular antagonist has been very helpful in treating people who abuse alcohol. So, like we were saying, so not only does it help, of course, with alcohol dependence, but it will also help with opioid dependence because it's blocking the euphoria with the opioid directly. Another example of an opioid receptor type, an antagonist, an opioid receptor antagonist, is naloxone. So naloxone is and this is very recently kind of gotten a lot of attention. A lot of people may recognize it as Narcan, and so what naloxone does is it essentially blocks the receptors from taking in any more opioids. So, for example, let's say you're overdosing because you took fentanyl, let's just say, and what's happening is your brain is still taking in those chemicals, and all the chemicals are binding to those receptors. Well, if you inject somebody, you can do it as inject it directly into the bloodstream, or you can do it basically up the nose. If you give a dose or two of Narcan or naloxone, what it does is it halts everything. It stops everything in its tracks. So the brain no longer takes in that opioid. And so the idea is that it completely halts the process and reverses an overdose. If you can get to the person in time, of course, if they've taken too much and you get to them too late, they could die. But if you can get to them within a particular window and administer naloxone, then essentially you can stop the overdose in its tracks. And it has saved lots and lots of lives because it works is very efficient, works very quickly. Now, some other agonists, ones that bind to opioid receptors: heroin, morphine, oxycodone, Demerol, codeine, so many more. And these, of course, vary in level of abuse potential, as well as how much punch they pack, right, in terms of effectiveness. So that's generally opioids. I'm going to go ahead and do these videos separately to do them kind of shorter at a time so that you're not listening to, a 3-hour long lecture.